Hello, my name is Emmanuel Antonarakis, and today I'll be reviewing some of the key papers and abstracts from last year, 2024, in the year in review. I am professor of oncology at the University of Minnesota and the Masonic Cancer Center. So first, an abstract by Dr. Fred Saad, efficacy of olaparib plus abiraterone versus placebo plus abiraterone in patients with metastatic CRPC with a germline versus a somatic BRCA mutation. This was a subset analysis of the PROPEL trial. Just to remind the audience and to set the scene, the PROPEL trial was a phase 3 study in first-line metastatic CRPC. Patients were not allowed to have previously received abiraterone. They had to have an ECOG status of 0 or 1. And this was the study that looked at the combination of a PARP inhibitor olaparib plus abiraterone in the first-line setting versus abiraterone alone with a placebo. This was a biomarker unselected study, which then had some post hoc analyses in the homologous recombination mutated patients and in the BRCA1, BRCA2 mutated patients. As you might recall, this trial led to the FDA approval of the combination of olaparib plus abiraterone, but only for patients with somatic or germline BRCA1 and BRCA2 mutations, and did not lead in the US to an unselected all-comer approval in the homologous recombination unknown or negative patients. So the issue that this abstract wanted to answer was, is there a prognostic difference? And is there a difference in the relative benefit of the combination of olaparib plus abiraterone according to whether the BRCA1 or 2 mutation was germline versus somatic only? And the key conclusion from this trial was that the combination of olaparib plus abiraterone seemed to benefit patients both who had a germline mutation as well as those who had a somatic mutation. The two curves on the left show progression-free survival for germline and somatic respectively, and the two curves on the right show overall survival for germline and somatic BRCA mutations respectively. So the magnitude of benefit was consistent in both categories. My conclusions from this abstract are that in first-line metastatic CRPC patients with a BRCA1 or 2 mutation, both patients with germline mutations as well as patients with somatic mutations derive similar benefit from the combination of olaparib plus abiraterone relative to abiraterone alone. However, the natural history of germline BRCA mutated prostate cancers is worse than the natural history of somatic BRCA mutations. And you can infer that by looking at the control arms of the two curves, and you can see that those with a germline BRCA mutation have a more rapid progression and a more rapid death than patients with a somatic. So even though the natural history of germline BRCA prostate cancer patients is worse, the relative benefit gained from the combination of olaparib plus abiraterone is roughly of equal magnitude in both scenarios. The important thing for me here is that we must be testing all patients for both somatic, in other words, tumor-derived mutations, as well as germline inherited mutations. If you stop at germline testing alone, you will miss about half of patients with BRCA mutations who only have a somatic mutation and not a germline mutation. And of course, germline testing can be done from a saliva sample or a blood sample. Somatic testing does require a tumor biopsy. This can either be a biopsy of the primary disease, in other words, the prostate cancer, or metastasis. And of course, more recently, we can now do circulating tumor DNA analyses for the somatic component. The next abstract is an adjusted analysis of the magnitude phase 3 study. Remember, this was the study of niraparib plus abiraterone versus abiraterone alone. The primary endpoint of this trial led to the FDA approval of niraparib plus abiraterone in patients, again, with BRCA1 and BRCA2 positive prostate cancer in the first-line mCRPC setting. One of the things that the investigators noticed in this trial was that there appeared to be an imbalance of baseline prognostic characteristics favoring the control group here. So one of the things they wanted to do was to see whether, after adjusting for those imbalances, whether the PFS and OS magnitudes of benefit, no pun intended, were preserved or even enhanced after correcting for these baseline imbalances. This was the design of the magnitude study. It was a randomized phase 3 trial. Again, primarily first-line MCRPC patients. They were allowed to have started the abiraterone up to 4 months prior to randomization. They had to have an ECOG 0 to 1 and a low pain score of up to 3 out of 10 on the BPI SF pain scale. This study had two separate components, a biomarker positive component and a biomarker negative component. As you might recall, the biomarker negative component closed early due to futility, showing no difference in PFS, and the biomarker positive component completed enrollment and showed a radiographic progression-free survival benefit, especially in patients with BRCA1 and BRCA2 mutations. So the purpose of this abstract was to look at the unadjusted versus the adjusted analysis for PFS and OS. The adjustment method is called the IPTW, which stands for the inverse probability treatment weighting method. I don't fully understand all the details, but suffice it to say that imbalances in baseline characteristics such as Gleason score and other prognostic factors could be accounted for. If you look at the left-hand side, which is the progression-free survival, you'll see an arrow showing that the unadjusted hazard ratio for PFS was 0.55, and after adjustment, using this IPTW method, the hazard ratio improved to 0.67 after adjusting for the baseline imbalances. Similarly, on the right side, showing overall survival, the unadjusted difference in overall survival produced a hazard ratio of 0.79, and when adjusting for these baseline covariates, there was an improvement in the OS hazard ratio down to 0.65, suggesting that after adjusting for these imbalances, the benefit from the combination of niraparib plus abiraterone persisted and, in fact, became greater than previously thought. So my conclusions from this post hoc analysis of the magnitude study, first of all, to remind everyone that magnitude was the randomized phase 3 trial in first-line MCRPC patients, initially leading to the approval of the abiraterone-niraparib combination for those that have BRCA1 and BRCA2 positive prostate cancer. There were baseline imbalances in the prognostic factors favoring the control group, and thus an adjustment was done to see if those imbalances could be eliminated. After these imbalances were adjusted for using the inverse probability treatment weighting method, the degree of PFS and OS benefit was further enhanced and amplified. However, in my humble opinion, the combination of niraparib plus abiraterone has not been widely used in the community due to a perceived lower efficacy of this PARP inhibitor ARPI combination relative to the other combinations which are available, including olaparib abiraterone, as well as talazoparib enzalutamide. The third paper, which I thought was quite important, was the overall survival analysis from the TALAPRO-2 trial, a phase 3 study, again in first-line metastatic CRPC patients comparing enzalutamide alone versus enzalutamide plus the PARP inhibitor talazoparib. The PFS was previously presented and published, leading to the FDA approval of enzalutamide plus talazoparib for patients with HRR-mutated metastatic CRPC. In this trial, what the authors presented now for the first time was the overall survival analysis, and importantly, this overall survival analysis was for the overall unselected patient population, including both the patients that had HRR mutation positive status as well as those that had mutation non-deficient or unknown status. Again, to remind the audience, this was a randomized phase 3 study of about 805 patients, first-line metastatic CRPC, ECOG performance status 0 or 1. Prior docetaxel and abiraterone were both permitted for hormone-sensitive disease, although that represented the minority of patients. Primary endpoint was rPFS with a key secondary endpoint of OS, and this is what is being presented here. In other words, the OS for the overall unselected population. In a quite striking fashion, the overall survival for the all-comer unselected population was positive. showing a hazard ratio of approximately 0.8, meaning a 20% relative reduction in the risk of death when you add talazoparib to enzalutamide as opposed to enzalutamide alone. And if you like looking at median survivals, this was about an 8.8 month improvement in the median OS from a median of 37 months in the control arm to a median of almost 46 months in the combination arm. When you look at the subset analyses, you can see that the overall survival improvement favored almost all of the subsets shown here. I do want to point your attention to the second to last row, which is the HRR status. Patients that had HRR deficient status, in other words, mutations in the HRR genes, had an even greater overall survival hazard ratio at 0.54, as opposed to those that had non-deficient or unknown HRR status, where the hazard ratio for OS was diluted up to 0.87. And the last row, I think, is also important. The survival improvement seemed to be present whether or not the patients had received prior abiraterone or docetaxel in the hormone-sensitive space. So a very consistent trend across groups. So my conclusions from the overall survival analysis first presented at ASCO GU 2025 is that, of course, the primary endpoint of rPFS was previously met and reported, but the new information here is that in the overall unselected population, there was an overall survival advantage with the combination of enzalutamide plus talazoparib versus enzalutamide alone. And in my opinion, I believe that this combination will likely be seeking expansion of the label for the combination of talazoparib plus enzalutamide for the all-comer population. Remember, at the moment, this combination is restricted only to patients that have an HRR mutation. But because the overall survival signal was seen in the overall unselected population, it is possible that the sponsor will seek FDA approval now for all patients, not just those with HRR mutations. So that could be a significant change if it occurs. The next abstract was presented by Maha Hussein and published in Clinical Cancer Research, and this is the final analysis of the BRCA trial. Here's the design of the BRCA trial. First-line metastatic CRPC patients with a BRCA1, 2, or ATM mutation, no prior enzalutamide, ECOG performance status 0 or 1. The unique aspect of this trial, even though it was a very small study of only about 60 patients, was that this trial had 3 different arms. One arm in which patients received abiraterone alone, second arm in which they received olaparib alone, and then a third arm where they received the combination of olaparib plus abiraterone. And the importance here is that in all the prior combination studies of a PARP inhibitor plus an ARPI, the control arm of all of those prior studies was the ARPI alone. There had never been a control arm of the PARP inhibitor alone, as done here, and there had never been a trial with 3 arms. The second unique aspect about this trial is that this trial had a built-in crossover design, wherein patients who received abiraterone first were allowed to cross over to receive olaparib upon their first radiographic progression. And conversely, patients starting with olaparib alone were also able to cross over to receive abiraterone upon their first radiographic progression. So by that design, the authors were able to infer whether the sequential use of one agent followed by the second was equivalent or inferior or superior to the combination of both agents given upfront from the beginning. This shows the primary endpoint of radiographic progression-free survival. The purple curve is the combination of abiraterone plus olaparib for those patients who got the combination up front. The red curve are those patients that got the olaparib by itself, and the blue curve, which numerically is doing the worse, are the patients that got the abiraterone alone. Now remember I mentioned about the crossover design, and the effect of the crossover can be exemplified here in this so-called swimmer plot, where if you cast your eye to the left-hand side of the screen, you see the light blue bars, which are converting into red bars. So the light blue bars represent patients that started with abiraterone, and then when the bar becomes red, that shows the point at which the abiraterone was switched to olaparib. If you look at the middle, you can see the patients in red began with olaparib as a monotherapy, and then upon progression, they switched to the abiraterone in blue. And then you can see in the third, on the right-hand side, those were the patients that got the combination of abiraterone plus olaparib from the very beginning. And if you add up the progression-free survival 1 and the progression-free survival 2, shown in the blue and red colors respectively, and you compare that to the right-hand side, the bars shown in purple, you can see even with the naked eye that the combination, the purple bars, seem to exceed even the addition of the blue bars plus the red bars, again implying that the combination therapy up front might be better than sequential therapy of one agent followed by the other. So my conclusions from Bracaway is that this is the only trial of combined PARP inhibition and ARPI with 3 arms and 2 control arms, one control arm with abiraterone alone and a second control arm with olaparib alone, both being compared against the combination. The trial had a built-in crossover design, unlike the registrational phase 3 trials, and the crossover design permitted patients starting with abiraterone to cross over to olaparib upon progression, and also patients beginning with olaparib to cross over to abiraterone upon progression. In my humble opinion, even accounting for this crossover, the combination of olaparib plus abiraterone appears to produce a better progression-free survival than the additive sequential PFS1 plus PFS2 that might be seen with the Abi to olaparib crossover or the olaparib to Abi crossover. And despite the fact that this is a very small trial with only 60 patients overall, in my opinion, this is the best evidence that combination therapy with PARP inhibition and ARPI might be better to sequential therapy one after another. The next abstract is a trial design presentation of the EvoPAR Prostate 01 study. This is a phase 3 registrational study examining a new PARP inhibitor known as saruparib. Saruparib is an oral first-in-class PARP1 selective inhibitor. What many people may not know is that there are at least 10 PARP enzymes. PARP1 is the most important, and the previous generation of PARP inhibitors would inhibit PARP1, PARP2, and a few of the other enzymes. And by inhibiting some of the other PARP enzymes, in addition to PARP1, that may contribute to the toxicity, but may not help the efficacy component. So here we have a new drug, saruparib, previously called AZD5305, which for the first time is a PARP1 selective inhibitor. It does not inhibit PARP2 at significant concentrations. And a previous study called Petra, which was the dose escalation study, as well as another trial called Petrana, showed that this PARP inhibitor, saruparib, could be safely combined with the most common ARPIs, including enzalutamide, abiraterone, and darolutamide. So those background studies have led to the design of this registrational trial. This is a study in metastatic hormone-sensitive prostate cancer. These are patients with metastatic hormone-sensitive disease, ECOG performance status 0 or 1. They are going to be tested for homologous recombination mutations at the time of screening. There are going to be 2 separate cohorts. There's going to be an HRR mutated cohort, and then there's going to be a non-HRR mutated cohort. These are patients who had an adequate next generation testing, which was evaluable but was negative for HRR mutations, meaning that patients who have a test that is uninterpretable or unknown will not be permitted to enroll in this study. They have to have a documented result, and that result has to either be HRR positive or negative. In the positive group, 550 patients will be randomized to a triplet therapy consisting of ADT plus ARPI of the physician's choice plus the PARP1 selective saruparib versus a control arm of doublet therapy consisting of ADT plus ARPI with a placebo. A very similar design will be conducted for the non-HRR mutated patients. So these are patients with a known absence of an HRR mutation. This cohort is bigger, 1,250 patients. And again, they'll be randomized to triplet therapy, ADT ARPI plus saruparib versus control arm of ADT ARPI. Primary endpoint is radiographic progression-free survival, and they will do this in 3 subsets of patients. They will do the rPFS in the BRCA mutant patients. They will do it again in the HRR mutant overall, and then they will do it separately in the non-HRR mutant. Overall survival will be a key secondary endpoint. The study is currently unrolling, and there are no results yet. So my conclusions from this trial design is to remind the audience that saruparib is the first oral PARP1 selective inhibitor that spares PARP2 and other PARP enzymes from being inhibited, thereby lessening, at least theoretically, the toxicity. For example, cytopenias are expected to be better with this agent. EvoPAR-01 is the first phase 3 study. They are not going to be going in a metastatic CRPC population, and instead they have selected the metastatic HSPC population as their first registrational study. This trial will enroll patients with both HRR mutations as well as those with known absence of HRR mutations. And here at this point, I want to remind the audience that there are 2 other trials evaluating PARP inhibitors in metastatic hormone-sensitive prostate cancer. The first is the TALAPRO-3 trial, in which ADT plus ARPI plus or minus talazoparib is being investigated, and also the Amplitude study, again, metastatic hormone-sensitive patients, with a combination of ADT, ARPI plus or minus niraparib. I also want to state very, very clearly that at this point in time, there is no FDA approval of any PARP inhibitor in the metastatic hormone-sensitive space, even for patients with known BRCA1 and BRCA2 mutations. So these 3 trials, the EvoPAR-01, TALAPRO-3, and the Amplitude, will be the first trials that might suggest that PARP inhibition in the metastatic hormone-sensitive space is indicated. The results are awaited for all 3 of those trials. Now let's shift gears to talk about some radiopharmaceutical drugs. This was the abstract presented at ESMO by Silke Gillessen. This was the long-awaited PEACE 3 trial, a European trial looking at patients with first-line mCRPC who were about to embark on enzalutamide with or without the addition of radium-223. Many of us, including myself, had sort of forgotten about 223 for a few years. It was FDA approved several years ago for patients with symptomatic bone-dominant metastatic CRPC. But here, this was the first trial, or one of the first large trials, to study the combination of radium-223 with enzalutamide versus enzalutamide alone in patients with primarily first-line metastatic CRPC who had not previously received enzalutamide. Patients were asymptomatic or mildly symptomatic. They couldn't have known visceral disease. The primary endpoint of this study was rPFS, with a key secondary endpoint of overall survival. Importantly, after the first 119 patients were enrolled in this study, and where there was a signal of increased bone fractures detected, the study was amended, requiring that all patients receive a bone-protecting agent such as zoledronic acid or denosumab. The radiographic progression-free survival endpoint was met, and this was very encouraging, as shown on the left-hand side. But the part of the study that took me by surprise and also shocked many of the people in the audience at the ESMO meeting was the very striking and large overall survival difference shown on the right, where you can see that 6 cycles of radium-223 when added to enzalutamide, improves overall survival by 31 percentage points, giving a hazard ratio of 0.69. The threshold that needed to be met with respect to p-value was less than 0.0034. And as you can see there, the p-value was under that. It was 0.0031. So statistically speaking, this was positive for a primary endpoint for a key secondary endpoint of overall survival. The side effects were slightly increased in the enzalutamide radium group, with more fatigue at 5.5% grade 3 versus 1.8% grade 3 fatigue, increased risk of fractures, 5% versus 1%, increased anemia, 4.6% versus 2.2%, and increased risk of neutropenia, 4.6% versus 0%. These are all grade 3 or grade 4 side effects. So my conclusion from piece 3 is that this trial showed a statistically significant and clinically meaningful improvement, not just in progression-free survival, but also in overall survival, when radium-223 for 6 cycles was combined to standard enzalutamide. Conversely, I want to point out, and we're going to review this in a moment, the use of lutetium PSMA, for example, in the PSMA-4 trial, did not show an overall survival advantage when used prior to docetaxel chemotherapy. We'll talk about that soon. The safety of the enzalutamide radium combination was quite reasonable, with a small percentage point of grade 3 fatigue, anemia, neutropenia, and also weight loss. And finally, if this combination is ever entertained, it should always be done so in the context of a bone-protecting agent. I should state at this point that in the US and in Europe, the combination of enzalutamide plus radium has not been approved by regulatory bodies at this point, although that may change in the future. Now, I did hint about the PSMA-4 study. This was one of the most eagerly anticipated trials, I would say, of 2024 in all of oncology. Here we're talking about lutetium-177 PSMA-617. This was the drug that was FDA approved 2 years ago in March of 2023 in patients with third-line metastatic CRPC who had previously received an ARPI agent and a taxane chemotherapy. And in that setting, this agent improved both progression-free survival and overall survival. So the question is, if you move lutetium PSMA-617 in the mCRPC pre-chemotherapy setting, patients who have not yet received chemotherapy for metastatic CRPC, will you also show the same degree of benefit? So this was the trial design. First-line mCRPC patients, the patients could not have received the taxane for metastatic CRPC. They all had to have received one prior ARPI agent, but not more than one. And then they were randomized to the lutetium PSMA-617 or an alternative ARPI switch, for example, enzalutamide in patients having received abiraterone, or abiraterone in patients having received enzalutamide. The lutetium-177 was given intravenously every 6 weeks for a total of 6 doses. The dose was 7.4 gigabecquerels. Importantly, the primary endpoint here was radiographic progression-free survival, and upon the confirmation of radiographic progression, patients in the control arm, the ARPI arm, were allowed to cross over and to receive lutetium PSMA. And strikingly, 84% of people in the control arm did actually cross over to receive lutetium PSMA. And I'll get back to this in a second because this may have influenced and perhaps diluted the overall survival advantage. So first, let's focus on the top left Kaplan-Meier curve. This shows the primary endpoint of radiographic progression-free survival. This was unequivocally met, as you can see, with a large separation of the curves. If you look at the bottom left, overall survival, not so different. And in fact, the hazard ratio for overall survival was 0.98, very, very close to 1, not statistically significant. Once again, it is possible that an overall survival effect may have been diluted because of the 84% crossover rate. Other endpoints, including PSA response and objective response also favored the lutetium PSMA group. Side effects, we can see more dry mouth with lutetium PSMA. We see more nausea. We see more anemia and diarrhea. But as you can see there, the grade 3 events were relatively low, and most of those side effects were grade 1 or grade 2. So my conclusions from PSMA-4 is that this is the first study to test lutetium PSMA 617 in the pre-taxane mCRPC space. We saw an improvement in radiographic progression-free survival, but not in overall survival, although the high degree of crossover may have influenced the lack of OS. The toxicity profile is very favorable, but does include dry mouth, nausea, diarrhea, and anemia. And very importantly, on March 28, 2025, approximately 2 years after the initial FDA approval of lutetium PSMA 617, the FDA expanded the use of lutetium PSMA 617 into the pre-taxane mCRPC setting based on the results of this trial. What this means is that a patient now who has failed or progressed after one single ARPI agent, for example, abiraterone or enzalutamide, who has not yet received chemotherapy and who wishes to defer or delay the use of chemotherapy, can now receive lutetium PSMA 617 prior to failing a taxane agent. I think this will be quite a transformative change in our practice pattern moving forward. Another interesting abstract also with lutetium PSMA 617, which was published also in the Lancet Oncology, was from Louise Emmett, and this is the overall survival of a previously reported study called the ENZA-P trial. The PFS had been previously reported, and now the overall survival is mature. So this is the design of the ENZA-P trial. These were patients primarily with high-risk first-line metastatic CRPC. They could not have received chemotherapy for CRPC. They had to have a positive PSMA PET scan. They had to be eligible for enzalutamide treatment, and then they were randomized to enzalutamide alone or lutetium PSMA 617 for a minimum of 2 doses and up to 4 doses. PSA PFS was the primary endpoint. Radiographic PFS and OS were key secondary endpoints. If you look at the left-hand side of this slide, you can see a clinically significant, but perhaps not statistically significant radiographic progression-free survival improvement with a hazard ratio of 0.68, but the confidence interval crossing 1. But what was more striking in this trial and unexpected, at least to me, was a statistically and clinically significant improvement of overall survival when adding 2 to 4 doses of lutetium PSMA to enzalutamide in the high-risk metastatic CRPC setting. So that was quite unexpected from my perspective. Again, the side effect profile, generally manageable, but there was an increase in fatigue, nausea, dry mouth, dry eyes, and some cytopenias, including anemia and thrombocytopenia. Again, most of those side effects were grade 1 to grade 2, although there was some grade 3 anemia, small fraction of grade 3 thrombocytopenia, with the combination of lutetium plus enzalutamide compared to enzalutamide alone. My conclusions from ENZA-P are that this is the first study to show an overall survival advantage when lutetium PSMA was used prior to taxane chemotherapy when combined with enzalutamide. Relative to enzalutamide monotherapy, the combination of lutetium plus enzalutamide improved PFS, although not to a statistical degree, also improved OS as well. There were other improvements, for example, in deterioration-free survival and time to pain, and also fatigue. The side effect profile was manageable with dry mouth, dry eyes, nausea, and cytopenias being the main side effects, but they were mainly grade 1, grade 2. But once again, I do want to remind the audience that at this time, the combination of enzalutamide plus lutetium PSMA is not currently FDA approved. And I would say that based on the fact that this was a randomized phase 2 trial, in my opinion, larger randomized phase 3 international trials are needed to confirm the benefits seen here. Another radioligand, which is similar to but different from lutetium PSMA 617, is called lutetium 177 PNT 2002. This was the SPLASH trial led by Dr. Oliver Sartor. This agent is a similar molecule to the lutetium PSMA 617. However, it has a different linker. So it still targets PSMA. It still delivers lutetium 177, but the linker that links the PSMA ligand to the radioactive molecule is different than proprietary, and thus it has a different name. So this trial was also a pre-chemotherapy metastatic CRPC study. Patients had to have received one prior ARPI agent, but no chemotherapy for mCRPC. They had to have a positive PSMA PET scan, ECOG performance status 0 or 1. Taxane was allowed, but only if it was delivered in the hormone-sensitive setting. And then patients got this particular radioligand, PNT 2002, at a dose of 6.8 gigabecquerels every 8 weeks for up to 4 cycles, versus the alternative ARPI. And here, the randomization was 2-to-1, favoring the radioligand group as opposed to 1-to-1. And once again, a crossover was permitted in the control arm, and in fact, large majority of patients, 84.6%, did cross over. RPFS was the primary endpoint, and there were a number of secondary endpoints as well. If you focus on the left-hand Kaplan-Meier curve, you will see that the primary RPFS endpoint was met, although perhaps the difference in the two curves was a little bit more modest than what we saw with PSMA-4 utilizing the lutetium PSMA 617 molecule. If you look on the right-hand side, overall survival was not different, and in fact, the hazard ratio was higher than 1.11 in fact, although the overall survival interim data is still quite immature. If you compare the PSMA-4 study with lutetium PSMA 617 with the SPLASH trial using lutetium PSMA 2002, you can see that the hazard ratio for PFS was 0.49 in PSMA-4 and 0.71 in SPLASH, suggesting that perhaps the SPLASH regimen may not be as superior as the PSMA-4 regimen. Similarly, with overall survival, although both hazard ratios are close to 1, the hazard ratio was perhaps a bit more favorable for survival in the PSMA-4 trial. And additionally, PSA responses and objective responses were a little bit higher with PSMA-4 compared to the SPLASH trial. Why might that be the case? Well, I'm going to speculate on that. First of all, just to summarize here, that the SPLASH study using lutetium PSMA PNT 2002 appeared to show a more modest RPFS benefit compared to the PSMA-4 trial utilizing PSMA 617. Here's my hypothesis, or at least one of my hypotheses. The dose and schedule of the radioligand was different in the two trials. In the SPLASH study, the dose was 6.8 gigabecquerels, given for up to 4 cycles. In the PSMA-4 trial, the dose of the radioligand was 7.4 gigabecquerels, higher dose, given for up to 6 cycles. So the cumulative total dose of radioligand therapy that was delivered in the PSMA-4 study was significantly higher than that in the SPLASH study. It is possible that a higher dose intensity that was achieved in PSMA-4 relative to SPLASH might potentially explain the slightly higher efficacy with respect to PFS. Finally, I want to remind everyone that lutetium PSMA PNT 2002 is not currently FDA approved, and it's not clear whether the sponsor will be seeking FDA approval based on these results, which were, let's say, lukewarm at this time. And we cannot currently use this medication in our daily practice. I've got one or two more important abstracts that I'll get through quickly. The first is the final overall survival analysis of the CONTACT-02 trial, a combination of cabozantinib plus atezolizumab versus a novel hormone therapy switch. Here's the trial design. It was previously published. The previous publication focused on the progression-free survival primary endpoint. This updated presentation now reports the overall survival. These were patients with metastatic CRPC. They had to have a prior ARPI agent. They couldn't have received chemotherapy for metastatic CRPC, and they had to have measurable disease based on a CT scan. They were randomized to receive either cabozantinib plus the PD-L1 inhibitor atezolizumab or the alternative novel hormone therapy agent. The updated presentation now reports the overall survival. Here, I just want to review the progression-free survival, which shows an overall improvement in the intention to treat population shown on the left. And then I also want to call out the liver metastasis subset and the bone metastasis subset, where you can see perhaps in the liver met subset, there is a greater degree of benefit with a combination of cabo plus atezo relative to the alternative androgen receptor pathway inhibitor. And here are the new data, overall survival. The punchline is that while the overall survival in the overall intention to treat population was not significant with the combination of cabozantinib plus atezolizumab, what we do see in the liver subset is perhaps a hint of an overall survival benefit with a hazard ratio of 0.68 and a p-value that was equal to 0.05, so just on the cusp of statistical significance. And then also perhaps a signal also in the bone metastasis subset showing perhaps an improved overall survival with the combination of cabozantinib plus atezolizumab in that subset as well. So my conclusions are that the CONTACT-02 study met its PFS endpoint that was previously reported. Here what we saw is that OS was not met in the unselected ITT population, but in the subset with liver metastases and to a lesser degree bone metastases, there did appear to be an overall survival trend, once again, primarily in the liver met subset. The side effects were primarily manageable and included the known side effects of cabozantinib, such as hypertension, diarrhea, anemia, hand-foot syndrome, and fatigue. It's important to note that in metastatic prostate cancer, neither cabozantinib nor atezolizumab are currently FDA approved in any setting, even as monotherapies. And although it's possible that regulatory approval might be sought for the liver metastasis subset, that approval has not been granted yet. One open question that I have in my mind is, does the atezolizumab add anything? And if you cast your mind back about 10 years, you might remember the COMET-01 and COMET-02 studies, which tested cabozantinib as a monotherapy in prostate cancer, and those trials did show a PFS improvement compared to placebo, and they showed a certain proportion of objective responses and PSA responses. So in my mind, I'm not sure whether there is true synergy between cabo and atezo, or whether this result may have been seen with just the cabozantinib alone. Dr. Schweitzer presented an interesting compound called mevrometostat. This is an oral EZH2 inhibitor that was combined with enzalutamide. EZH2 is an epigenetic regulator that affects the chromatin states. When the chromatin are tightly wound, they prevent the expression of genes, including tumor suppressor genes. When those chromatin become unwound by inhibiting EZH2, it allows several genes, including tumor suppressor genes, to be expressed. The hypothesis here was that if you inhibit EZH2 and you add an anti-androgen like enzalutamide, you will reverse secondary resistance to the enzalutamide. You will prevent lineage plasticity, and the emergence of the so-called neuroendocrine state. So the trial design was patients who had received prior abiraterone and progressed. They now had metastatic CRPC. They could have received one prior chemotherapy regimen, and then they were randomized to enzalutamide alone in the post-abiraterone setting, or the combination of enzalutamide plus the oral EZH2 inhibitor, now known as mevrometostat. Primary endpoint was radiographic progression-free survival. The primary endpoint was met. When mevrometostat, the EZH2 inhibitor, was combined with enzalutamide, there was an improvement in radiographic progression-free survival by about 50%, with a hazard ratio of 0.51. You can think of that approximately as a doubling in PFS, and you can also see a doubling in the objective response rate and a doubling in the PSA 50 as well. Side effect profile: this agent primarily affects the gastrointestinal tract, so diarrhea, anorexia, nausea, and taste changes are the main side effects. Anemia was also seen, as was alopecia. 40% of patients had some degree of hair loss, despite this not being a chemotherapy agent. My conclusions from this randomized phase 2 study is that mevrometostat, the oral EZH2 inhibitor, enhances the efficacy of enzalutamide in the post-abiraterone mCRPC setting, producing a hazard ratio of about 0.5. Mevrometostat at a dose of 875 milligrams combined with food is now going to be recommended as the phase 3 dose. The adverse events of this agent are primarily GI in nature, with diarrhea, nausea, taste changes being common, and also some degree of alopecia. There are 2 phase 3 studies that have been designed and are about to open: the MEVPRO-1, which is a post-abiraterone metastatic CRPC study, and the MEVPRO-2, which is a pre-abiraterone ARPI naive study. In both of these trials, enzalutamide plus placebo is going to be compared against enzalutamide plus mevrometostat. And finally, I want to talk about another new agent, the CYP11A1 inhibitor, now known as opevesostat, and this is now being tested in 2 phase 3 trials. Before we get to that, let's discuss this medication. It used to be called ODM-208, was then changed to MK-5684, and is now known as opevesostat. This is an oral inhibitor of the CYP11A1 enzyme. This is an adrenal enzyme that converts cholesterol to pregnenolone. It's the first step in the adrenal steroid synthesis pathway, as you can see on the left-hand side. When you inhibit CYP11, you're inhibiting androgen synthesis, but you're also inhibiting glucocorticoid and mineralocorticoid synthesis. By decreasing the supply of glucocorticoids and mineralocorticoids, you're preventing those alternative steroid ligands from binding to the androgen receptor. And on the right-hand side of this diagram, you can see that there are certain mutations in the androgen receptor gene that cause other promiscuous steroids to bind and stimulate the androgen receptor. For example, glucocorticoids can stimulate the AR in the context of that L702H mutation. Progesterone can stimulate the AR in the context of the T878A. Estradiol can stimulate the 875Y. In the phase 2 study that was previously published by Dr. Karim Fizazi, called CYPIDES, you could see that this agent had activity both in patients without and with AR activating mutations, but the activity was greater in those with the AR mutations, as shown on the left. And because of this promising activity in the phase 2 trial, there are now 2 ongoing phase 3 randomized studies testing this agent. The first is called Omaha 004. This is a pre-chemotherapy metastatic CRPC study. Patients have to have failed 1 prior ARPI. No chemotherapy is permitted except for docetaxel in the hormone-sensitive state. And then they're randomized to the oral opevesostat plus hormone replacement therapy with dexamethasone plus fludrocortisone versus the alternative novel hormone agent. At the bottom, the design is virtually identical, except that in Omaha 003, this is a post-chemotherapy trial, so patients are required to have failed one ARPI and 1 to 2 taxanes in the CRPC setting. And once again, they're randomized to either opevesostat plus hormone replacement, adrenal replacement therapy versus the alternative ARPI. Both of these trials are powered for both PFS and OS, and they are powered for both AR mutation positive and AR mutation negative patients. So my conclusion here is that opevesostat is an oral CYP11 inhibitor that suppresses production of all adrenal steroids. It has shown clinical activity in phase 2 studies, primarily in patients with AR mutations, but also in some patients without. The Omaha 4 and Omaha 3 studies are randomized trials testing opevesostat versus ARPI switch in the pre-chemotherapy and post-chemotherapy settings, respectively. However, because this agent is basically a medical adrenalectomy, you need to supplement these patients with both glucocorticoids, such as dexamethasone, as well as mineralocorticoids, such as fludrocortisone.